Hello everybody, in this video we will be discussing about an important movement disorder and the Parkinsonism disorder from the medicine point of view. So let's get started. First terminology is athetosis. What is athetosis? Athetosis, it is a slow worm-like crawling movements in the distal limb. Athetosis is occurring because of the lesion in the globus pallidus. The second is chorea. Chorea, it is a semi-purposeful dance-like movements which occurs in a distal limb. The chorea happens because of the lesion in the caudate nucleus. Hemibalismus and the balismus, it is a terminology. In this, there is high amplitude flinging movements in the proximal limb. The lesion is in the subthalamic nucleus. Now we'll be discussing about the types of rigidity. There is cogwheel rigidity seen in the Parkinson's disease, lead pipe rigidity seen in the extrapyramidal lesion, and the clasp knife rigidity seen in the pyramidal lesion or the corticospinal lesion, that is the upper motor neuron lesion. Now we'll be discussing about the tremors. There are four main types of tremors. First is the intentional tremors. In intentional tremors, tremors appears on reaching the target because of the lesion in the cerebellum. To test the intentional tremors, we do a finger nose test. Flapping tremors are seen in the hepatic and the uremic encephalopathy. Fine tremors are seen in thyrotoxicosis, and the essential tremors, it is an autosomal dominant condition. The tremors are of 6 to 10 Hz, which are bilaterally symmetrical tremors. This kind of tremors, that is the essential tremors, it increases on anxiety and it decreases on alcohol intake. For the essential tremors, the drug of choice is propranolol, but in patient like asthma, we cannot give beta blockers. So in that case, we can give primidone. And if the patient is non-responsive to propranolol or primidone, we give deep brain stimulation. Now we'll be talking about the main important movement disorder, that is the Parkinsonism. What happens in the Parkinsonism? In Parkinsonism, there is misfolding of the alpha-synuclein. Because of that, there is aggregation leading to an atrophy of the midbrain. Now, what does the Levy body do? Levy body, they are an eosinophilic inclusion body. They hold this misfolded alpha-synuclein inside the neuronal cell cytoplasm. Now we'll be talking about the role of substantia nigra pars compacta. Normally, this substantia nigra pars compacta, it generates the dopamine, and dopamine works at the striatum by the nigrostriatal pathway. But in Parkinson disease, this Levy body get deposited in the midbrain, leading to an atrophy of the midbrain, the hypopigmentation of the substantia nigra, and it decreases the dopamine level. Now, the etiology of the Parkinson disease. There are four main etiologic factors. First is idiopathic, which is the most common type of Parkinson disease. Second is inherited or familial. These are mostly autosomal dominant. The gene involved is LRRK2 gene on the chromosome 12. Third is iatrogenic, which is the most common cause of secondary Parkinson disease, which includes the drugs like dopamine inhibitors, typical antipsychotics, metoclopramide, lithium amiodarone, dopamine depleters like tetrabenazine and reserpine. Toxins like carbon monoxide, manganese, and MPTP, which are used by the heroin addicts. Now, the clinical features of the Parkinson disease, the tremors are occurring. What kind of tremors? Restrained tremors are occurring. And the tremors, it is a most first motor symptoms, which the tremors are of 4 to 6 Hz, and this restrained tremors that disappears during the activity and on the sleep. Second clinical feature is rigidity. We have already seen that cogwheel rigidity is seen in the Parkinson disease. And third clinical feature is bradykinesia, which is the most essential clinical feature. Other motor symptoms occurs in the Parkinson disease like micrographia, mask-like face, And the monotonous speech, the speech will be soft, low pitch, whispering voice. And the non-motor symptoms is depression, dementia, and the anosmia. Now the treatment of Parkinson disease. First is the dopaminergic agents. We give levodopa as a dopaminergic agent, which is drug of choice after 60 years of age. What levodopa is converted into the dopamine, and that 1% of dopamine crosses the blood brain barrier and increases the dopamine level inside the brain, which the symptoms of the Parkinson, that is rigidity and the bradykinesia, disappears. But now the levodopa is also converted into the dopamine by the decarboxylase enzyme, but the dopamine which we get, it do not crosses the blood brain barrier, thus precipitating the rigidity and bradykinesia. This is known as the wearing off phenomena. Another dopaminergic agent we can give is amantadine, which increases the dopamine level, and the dopamine agonist can be used in the oral form, can be used in the transdermal form, can be used in the injectable form. The oral dopamine agonists are ropinirole, pramiprazole, the transdermal is rotigotine, and injectable is apomorphine. Another treatment in Parkinson, we can also use the dopamine inhibitors like decarboxylase inhibitors, that is carbidopa, COMT inhibitors, that is entacapone and tolcapone, and MAO-B inhibitors such as rasagiline and salicyline. And to decrease the level of acetylcholine, as in Parkinson the acetylcholine level was increasing, which was causing tremors. We need to decrease the tremors by giving anticholinergic drugs like trihexyphenidyl. The drug of choice in the patient age less than 60 years is dopamine agonist, and in the patient age more than 60 years, the drug of choice is levodopa. The neuroprotective drug is rasagine, the antidepressant drug is pramiprazole, and the antidyskinetic drug is amantadine. If the patient is not responding to the medical therapy, or the patient is having intractable tremors and the drug induced dyskinesia, we can also do the surgery, that is deep brain stimulation. Now this was all about the Parkinson disease. The next movement disorder is atypical Parkinsonism. In this there are three topics, that is progressive supranuclear palsy, dementia of the Lewy body, and the multiple system atrophy. In progressive supranuclear palsy, there is extended posture, defective downward gaze, and dystonia. In dystonia, you can see the wrinkles on the forehead can be seen on the surprised look of the patient. Second topic is the dementia of the Lewy body. In the dementia of the Lewy body, we are gonna seeing the Parkinson disease plus visual hallucination plus the dementia. The onset of the dementia will be less than 1 year. Third topic is multiple system atrophy. In multiple system atrophy, we will see the features of the Parkinson disease, the cerebellar symptoms, which are known as MSAC, the autonomic symptoms known as MSAA. This was all about the movement disorder, including the Parkinsonism and the atypical Parkinsonism. This was a very short and a crisp summary of a movement disorder, which will help you in the last moment for revision for the NEET and INICET. I hope you all enjoy. Thank you very much.